treat to be able to do this. I only wish I could see you all. So what I wanted to do today is figure out how to make my screen move. There we go. The learning goals that we're going to cover quickly in the next 55 minutes or so is obviously to know the key aspects of ethical decision-making and how to apply the Ombudsman Code of Ethics, and to have a set of questions that you can have in your possession to kind of stay grounded when you get in the thick of things and are wondering, have you done the right thing? Have you done everything that you could for the resident? And also to kind of reinforce what we're talking about today by showing what the new Ombudsman Program Rule does in terms of supporting this ethical approach to complaint processing. So I'm hoping that during this time you will stay interested, engaged. I hope you have the handouts that I sent to Carla recently. If not, you can print them and have them after this presentation. But put on your thinking caps and let's just kind of plunge ahead with some of these situations. And as Amity said, we'll have some time for discussing a couple of different cases, and then we also will have some time for questions and general discussion, and we'll conclude by talking about some of the resources that are available on this topic. So the first thing is, what is ethics? And Amity, if you would unmute the line, I would like one or two responses. How do you define ethics? What is that?
Anybody have input on what you would consider to be ethics? We're having a very quiet group.
I can tell.
Right, and what is wrong?
Morals.
Morals. Integrity.
Okay, great. Thank you for jumping in. And so, Amity, I think you can mute it again. And you nailed it. Basically, ethics is a set of moral principles. It's a theory or system of values and the principles of conduct governing an individual or a group. And basically, it's a guiding philosophy. So if we were face-to-face, I would ask you some more questions and wait for responses. I think I'll just move ahead in the sake of time since we have an hour together today and basically say, you know, what are the core principles? What is the guiding philosophy for ombudsman? And generally we think of it in terms of the problem-solving process. You know, that's you receive and identify complaints or concerns, you investigate them, you work to resolve them, and then you follow up. The other principles and guiding principles for ombudsman, obviously the Older Americans Act, the Long-Term Care Ombudsman Program Rule, which now clarifies the Act, and then any state regulations or policies and procedures that you have, and then other kinds of documents that are out there. But then it also, when I first started delving into the area of ethics, it made me wonder about, okay, so you have the Older Americans Act and the Ombudsman principles and your training. Why is it really important to talk about ethics, and where does that fit into how ombudsmen work? Don't you already have enough guidance with the Older Americans Act and the responsibilities that are delineated there? The Code of Ethics for Ombudsmen kind of undergirds everything you do, and it was developed and designed by state ombudsmen, and then local ombudsmen developed one that's more specific in terms of ombudsman practice than the one that we've referred to for many, many years. But basically, the Code of Ethics was developed because a number of ombudsmen came from professional backgrounds, nurses, social workers, other kinds of backgrounds where their professional training and grounding, they had a set of prescribed code of ethics. And people would become ombudsmen and say, what's our code of ethics? What's our professional code? So the ombudsman decided to develop one based on the provisions of the Older Americans Act. And it's come in very handy because, as you well know, the work that you do every day is not always black and white. You kind of put on your wading boots and go through the ambiguity areas or the gray areas and kind of have to wade through it and stay clear. As you know, you have all kinds of residents with whom you work. Sometimes it may not be so clear-cut what's the right thing to do or the best thing to do, yet you are called upon to work consistently on behalf of being a resident advocate and to maintain the credibility of the program and to work with integrity. That's one of those ethical principles that some of you were mentioning previously. And basically, the Code of Ethics was designed to help guide you in, are you going the right way, or is the thing that's on the table for discussion, or however people are trying to push you to work or act, is that kind of pushing you off the core of ombudsman work? Does that make your ability to work with integrity a lot more messy? So that's how the Code of Ethics really fits and underscores what you do. So basically, what are some of the provisions in the Code of Ethics? I have a few here on the screen, and I am assuming that most, if not all of you, are very familiar with the Code of Ethics. When you look at it, it talks a lot about services with respect for human dignity. It talks about the individuality of the client, and the Ombudsman chose to use client because even back when these were developed, some programs were serving individuals in home and community-based services, the long-term care ombudsman programs. It's talking about respecting, promoting clients' right to self-determination. The Ombudsman makes every reasonable effort to ascertain, act in accordance with clients' wishes, acts to promote vulnerable individuals from abuse and neglect, and you provide professional advocacy services unrestricted by your own personal belief or opinion, yet you act in accordance with the policies and practices of the program, and at all times you take action and conduct yourself in a way that will strengthen the statewide and national ombudsman network. I think if you look at all the provisions in the Code of Ethics, they kind of can be distilled into two big categories. One has to do with respecting and relating to clients or residents. So what is your relationship and how do you help support them? And the second one that you could group a number of the provisions of Code of Ethics in is that the Ombudsman always acts in accordance with standards and practices and in a way that strengthens and is credible for the program and the national network. A few more things as we talk about what ethics really means and how you do them as an ombudsman. We had Jackie Glover present to a group of ombudsmen a few years ago, and she's an ethicist and philosopher. And she talked about ethics is about the process as well as what you do. It's not just the outcome, but it's how you get there. And good ethics begins with good facts. That's where your investigation comes into play. You're talking with people, you're listening, your observations, you're pulling back from what you're being pressured to do and to act right away and being thoughtful about what you know. And then one thing that I thought was particularly helpful is to know that there's always a range of morally acceptable actions. So it's not just only one correct decision. There may be a range of ways to get there, but it's trying to make sure that as an ombudsman, you are really grounded in your role and you are focused on how you can empower and support the resident and what that individual wants, or as close to that as you can possibly ascertain and come. In terms of decision-making capacity, this often arises whenever people are talking about ethical issues. And another philosopher ethicist who did a lot of work with ombudsman programs reminded us once that a person's ability to make autonomous, informed consent decisions is never really questioned until they make a decision that really differs from what professionals or family members would choose. So it's when you make a decision that somebody else doesn't like they begin to say, well, you can't really give her what she says a lot of credibility because she does have some form of cognitive impairment, or I guess she's getting so old now that she's just not that reliable. Or how many times have you had people, staff of facilities, tell you that you really can't trust what someone's saying because what they're saying is, they have a diagnosis of dementia. So I've learned over the years that whenever somebody tells you why you can't trust or believe what a resident's saying, it's really important to stop and say, why is that person saying that? What's their motivation? What's the basis in real facts and grounded in the real world versus they have some other motivation? So it's going back to decision-making capacity really isn't questioned usually unless it differs from what the decision other people think they should make. So basic principles for decision-making that I'm sure you're familiar with: informed consent and autonomy, substituted judgment, and best interest. Usually we would stop and talk about these some in depth, but I'd like to move to the case scenarios and have time for some discussion. I think we all well understand what informed consent and autonomy means, although I think it's common for ombudsmen to find that residents and family members are not always making a decision with informed consent, that maybe they have only one or two options presented and it's a take it or leave it, and nobody's really explained to them the trade-offs or that there are other avenues that could be pursued. Substituted judgment is how much do you know about the values and what the person would choose if they could exercise a choice, if they could express their choice and make a decision based on their characteristics, statements they've made in the past, people who are really close to them. What would they choose if they could choose? And then lastly, best interest. And that's, what do you think are the ways, the benefits, and the pros and the cons, and decisions made in the best interest of the person. And as ombudsman, you move through these in this kind of order, always seeking autonomy and informed consent. And even individuals with impaired decision-making can sometimes be very clear about what they want with certain decisions. And then go to substitute judgment. If there is a resident representative who has the authority to make a decision in one area of that person's life and the resident can't really exercise their decision-making, they cannot tell you what they want or give you an indication, sometimes it's helpful for ombudsmen to remind that person or to ask questions. I mean, you don't remind them of their responsibility necessarily, but ask them, so what do you think this person would choose? What have you heard her saying? What has she done most of her life? So that you're trying to nudge them toward making the decision that the person would choose if she could, not that necessarily what the resident's representative really thinks needs to happen. You may have to try to get them back to resident-centered decision-making. And the rule has provided more specific direction in terms of certain circumstances regarding consent. I want to run through pretty quickly some of the provisions in the rule. This complaint processing, it fits very closely with the problem-solving process that we've discussed for years, and that's been in the training and in the core ombudsman training since the very earliest days of the program, which is that the ombudsman and the representative of the office serve the resident of the long-term care facility. So that's your starting point, that's your end point. And then the rule also talks about that ombudsman can investigate complaints having to do with abuse, neglect, and exploitation for the purpose of resolving it to the resident's satisfaction. So it's a different purpose than law enforcement, adult protective services, and others investigate abuse, neglect, and exploitation. And then the rule also talks about Ombudsman can investigate complaints for residents who are unable to communicate informed consent and do not have a representative. And there are a number of different qualifiers and guidance listed in the rule around how you approach that kind of scenario. Complaint processing, continuing along those lines, regardless of the source of the complaint, which could be you or someone else, the Ombudsman, that's you or Carla, must support and maximize resident participation throughout. And it talks about you have to personally discuss the complaint with the resident and determine the perspective of the resident. You get their consent on whether or not they want you to do anything. And there's some provisions around oral consent and the ways that that needs to be documented if the person cannot consent in writing. And then you need to determine what the resident wants with respect to the resolution of the complaint and whether or not the allegations are to be reported, and if so, do they give you consent to reveal identifying information if you report the situation or the complaint to anybody else. And you have to keep the resident informed about residents' rights, work with the resident to develop the plan of action or resolution, investigate the complaint to determine whether the complaint can be verified, and determine if it's resolved to the satisfaction of the resident. I know that sounds like a lot of work and a lot of contact with the resident, but in a nutshell, that's how the program, why the program began, and how its origins are rooted, which was to be resident-directed and be at the service of residents. And if you are seeking to empower them and engage them, then you, as Ombudsman, have to walk the talk and let them direct you. And I know we've heard Ombudsmen all around the country talk about, well, that sounds good, but it really slows me down because I could resolve a lot more complaints if I could just get the complaint, resolve it, and then touch base with the resident to see if it's resolved to their satisfaction. On the other hand, if you have that kind of approach, you are taking a shortcut, I guess, around some of the steps in the complaint process, as well as the opportunity to try to bring residents along with you and empower them in helping them understand how they can talk with others and resolve problems and issues. And by the same token, the complainant, you may, in fact, probably many times do work with a family member or someone other than the resident directly, and you are walking them through the steps in the problem-solving process, but always asking them, what would your mother want? What would your mother choose? What would she find acceptable? If and only if the resident cannot tell you directly. So at the heart of it, it is person-centered complaint processing, and we've had a lot of information from CMS and others over the years on person-centered care planning, person-centered approaches, and even some of the regulations are written that way now for providers. And basically, the Ombudsman rule spells out what it means for an Ombudsman to be person-centered. And obviously, it's really clear about your role and in terms of how you go about obtaining decision-making and trying to support the resident in exercising rights. I told you that there were some provisions in the rule around revealing resident identifying information under certain circumstances. I'm not going to spend a lot of time on those now, but basically there are certain circumstances and then checkpoints that you have to go through before you act without being able to get consent. And then the last one is you need the approval of the state ombudsman or follow the policies of the state ombudsman program in terms of when you move forward when a resident cannot communicate consent and the resident representative, there is no resident representative, or if the problem is with the actions of the resident representative. Tips for your practice. Conflicts usually arise, which means when you get called in, when there's an issue over the application of values instead of over the values themselves. This is something else to keep in mind when you're resolving problems or trying to figure out what are the right questions to ask or how do you approach something. It may be that the resident's family member, the staff, all agree that they want the person to have a good quality of life, or they want the person to be able to not lose weight, or to be able to get better so they can transition home. So it's not so much that people disagree over what the real value is or the outcome, it's how you apply it and how you get there, and whose values supersede the residents, basically, or someone else's. And it may be that for a resident, having more time to get started and get going in the morning is more important than making sure that they get up and participate in one more activity during the day. When maybe the family member thinks they need to be up and out of the room and doing some things so that they're engaged and have some socialization. So it's the application of the values and what the values are themselves. Values emerge from relationships, and they may change and evolve depending upon who's involved in the conversation. So for instance, ombudsmen are really good because it's in our training in the law that we are resident focused. On the other hand, some individuals really, it's important to them to know what their family thinks or wants. And I'm sure you've seen this where a resident may back off of some of the things that she has told you she really wants are important to her when she finds out that her son or daughter really objects to that. Or she may give up insisting on getting up at a certain time of day and have a wider window of what's acceptable because her favorite staff person she knows is just really stretched, and she doesn't want that to add stress to that person's life, which of course leads to a whole other issue around staffing. But it's, in some cultures, people make decisions based upon family input, and it's more of a group consensus thing. So for an ombudsman, you just need to be aware of who's important to that resident to be involved in the relationship and who needs to be part of the conversation. And people may change a little bit what they focus on as the situation changes. Basically, and Joan Gibson said this to us, but I think it's really important, and I see ombudsmen doing it continuously. Your role, obviously, is resident advocate, but a lot of what you do that's really important is that you identify people who need to be involved in the conversation with the resident when conflicts arise. And at the same time, you have to have a pretty high tolerance for ambiguity. And going back to something we talked about a few minutes ago, the key is the process that you use to sort out the options and arrive at a choice. It's not just jumping to the end. And sometimes you are the people who slow the process down, which a lot of people don't appreciate at all because you're trying to slow it down and make sure that the right people participate or the right questions are asked or the right kinds of information, going back to good facts, is available. So some questions that ombudsman might ask if people are disagreeing about outcomes and procedures. What harm will be prevented? What good will be done? What is the real issue? And you may be running through these in your mind when you get into a real murky situation, or it may be that you ask some of these questions and try to get the right people involved in talking about them. And then what else needs to be known to make or assist in this decision? And it's most especially, what are the client's or residents' questions or concerns? Oftentimes, these are very different than the questions and concerns of professional staff. And sometimes things are cleared up when the resident has the information that they want, and it's not nearly as complicated as it may seem. So right before we get to a case scenario, I want to remind you that you have some helps. You can push the help button. Obviously, we've talked about the Code of Ethics, the Older Americans Act, the rule. We've talked about some principles for applying the ethical concepts. And the last thing I wanted to talk about and just mention to you, because it's on one of the handouts in more detail, is identifying situations for self-check. And these are kind of the list of questions that you might want to ask. And I encourage Ombudsmen to pull these out when you get into a really messy situation, the checklist, and kind of see, okay, where are you with staying true to the Ombudsman role and the Ombudsman Code of Ethics and being the best representative of the resident that you can possibly be. Or if you get part of the way through and it's like, gosh, where do I go next? Pull out this checklist and start going down it and being thoughtful about your actions. We once had a state ombudsman tell us that he had been through somebody's file, a case file that was like back when there was a lot of paper documentation, an inch or two thick of all the contacts they had had with the resident and the family for several months. And he was stepping in to see what he could bring to try to, in terms of an outside perspective to the ombudsman, to try to get things resolved satisfactorily for the resident. And in reading it all, he came to realize that the ombudsman had gotten really caught up in all the different back and forth with family members and the demands of the family, and had kind of lost sight of, at the bottom line, what the resident really wanted, and had become more of an ombudsman to the family than the resident. So for that reason, it's important sometimes, if you don't really feel good or you have some internal dissension you feel going on in your gut, to stop and try to identify what is it you're feeling and why. Is it that the person's making a different decision than you wish they would? Or do they have a different value system? Are you concerned about what may happen to them ultimately if you help support them in making that decision? And then it's going into, okay, whose interest am I representing? And have I followed good protocol if the resident cannot express their wishes, and going on through these. But the checklist came out of numerous conversations and work with Ombudsman, and was field tested with Ombudsman over the years. So case discussions, we have two. I think we'll get to one, and then the other one you have on a handout, and at some point you may want to go through that with Carla or with your, just with your peers. So the case that I want to talk about is Mrs. Irons. The social worker at the Pines Nursing Facility calls and says the facility needs your help with the situation. A resident, Mrs. Julia Irons, is refusing treatment. Her doctor ordered a puree diet, and she refuses to continue eating it and insists that she wants a regular diet. Although she has terminal illness, she's not on hospice, and she's mentally sharp. She can make her own decisions. The facility staff are concerned that she will aspirate and die if she eats a regular diet. Ms. Irons said that she's willing to take the risk in order to have food that tastes and looks like real food. Some of her family members support Ms. Irons' decision. Others are strongly opposed. They take out their frustration on the staff, who feel like they're caught between upholding residents' rights, complying with medical orders, and possibly contributing to Mrs. Irons' death. So the social worker says, would you please come and work out a solution. Now, this is based on some suggestions from North Dakota, actually, so I'm assuming that some of you have something similar. So the question is, or there are several questions. One is, who is your client and why? What are the ethical and values issues? And what actions would you take? What questions or uncertainties might you have about your actions? And how do you know if you've done the right thing? In other words, how can you sleep at night without letting this just kind of keep you going about whether or not you really represented the resident well, or have you in some ways contributed to less quality of life or maybe hasten death? So, Amity, if you will unmute their line, I'd like to kind of get some of your response. So who's the client? Who's your client?
Who would you all consider to be your client? I'm hearing Mrs. Irons. There's pretty much consensus that it's Mrs. Irons.
Okay, and so what would you have? The social worker called you to come out and deal with the situation. How do you make sure that Mrs. Irons is your client?
What are the steps you would take so that you would clearly identify that you're there to represent Mrs. Irons? But as the Ombudsman, we are the resident representative, not the family representative. So, are you hearing this, Sarah, or do I need to repeat it?
No, you need to kind of recap it. Sorry. I can hear that somebody's talking, but I can't hear what they're saying.
Okay. All right. We're having the comment made that we also need to take into account the family's concerns and issues because they have to live with those as well.
Okay, that's correct. And Mrs. Irons would be your client if you can go to her and she says, yes, she'd like to help you, she'd like your help with a different diet. But you're absolutely right in terms of you need to understand where the family's coming from and what they want, because that's another set of issues around Mrs. Irons' diet. So what are the ethical and values issues? Just name a few of these.
Okay, the comment is made that with resident rights, she has the right to make that decision to have what she considers to be real food. Any other comments? Compromise and have a soft diet. Get the doctor's input. Okay, but let's go back to the question, what are the ethical and values issues that arise regarding whether she should have to stick with the diet or not? We talked resident rights. Are there other ethical and values issues?
Issue is the right to decide whether she wants to live or die.
Right to decide whether she wants to live or die. And right to refuse any medications. But that's a medical model. If you go to the resident directing us, should she make the choice whether she wants that food or not?
We all have the right to risk. We all have the right to put ourselves in danger and risk.
The comment is being made, Sarah, we have the right to risk and put ourselves in danger. right to live in harm as long as you're not harming others. I'm repeating it for Sarah, so.
Yeah, okay, so I think all of you are spot on. Those are some of the value and ethical dimensions, because obviously she does have the right to make decisions or to refuse treatment. She has the right to choose her risk and what level of risk she's willing to accept. And I mean, when it comes right down to it, we all make trade-off decisions all day long about risk benefits, just even getting in a car and driving to work. And she has the right, as some of you mentioned, to decide, is the risk of aspirating and maybe leading to death worth it to her to have food that she really enjoys, that tastes and looks like food? And some of you were getting at what actions would you take? When you were talking about maybe getting input from the doctor, talking with the family, maybe there are some compromises that wouldn't be pureed diet necessarily, but something that would still seem like real food and taste like it, look like it, smell like it. Or maybe there are some types of food that she could have that would be less risky in terms of leading to aspiration. And you also would want to talk with the staff some more. Of course, all of this is predicated upon Mrs. Irons giving you permission to do that, as well as finding out the family's input with what they really think is most important, but then trying to get all of those individuals together, talking with Mrs. Irons and listening to her, so that jointly there could be some decision made about moving forward, and hopefully a variety of options on the table for choice and how things could be started and tried. So looking at number 4, what questions or uncertainties might you have about your actions? So let's say you help Mrs. Irons understand her right to refuse treatment, her right to take risk, that she basically is in the driver's seat for a lot of these things, and you know what other people's concerns are at this point in time and what they're advising, and you want to try to get people together to come up with a joint solution, and yet it's Mrs. Irons' choice. But would you have any kind of nagging questions or uncertainties about what to do or what you have done?
Okay, visit with the family and have them express their concerns to Mrs. Irons. And yeah.
I think the negotiation should be with the family, the first people that love her, because they're in disagreement. What this tells me is she's willing to take the risk. She is mentally alert and smart. I could say the simple solution is she wants to live the rest of her life, or however long it will take, to enjoy food. I mean, any of us would sooner eat this thing that tastes good rather than cheese that are whipped into gravy. So let her enjoy life.
Okay, so the comment being made is to let Mrs. Irons enjoy life and to support that. Would that then make you start to question that, wow, by advocating for the right for Mrs. Irons to have regular food and the chance that that might cause her to aspirate and die, would that give you an uncertainty about advocating for that action?
The information says that faculty staff are concerned. That might be not the medical staff, the dietitian or the cook. What do they do?
Okay. So that's what we're getting here, Sarah, is that, you know, get more information about really the risk of aspiration. That's what's being said here.
Okay, and I also think I heard somebody talking about her right, Miss Irons' right to enjoy food, and she may have a higher value for quality of life than she would for the potential of shortening her life by, who knows, if she has a terminal condition but she's not on hospice. It could be a short amount of time, it could be a long amount of time, but it's a risk-benefit of priorities of values that she apparently is wanting to exercise. And you're right, there may be a range of things that could be done that would be beneficial. I think as an ombudsman, if I had Mrs. Irons as a resident and was trying to help her resolve these issues, I might always, or at least in the short run when you're trying to resolve it, wonder, okay, did I do anything that's going to make life more difficult for her, or was I a little too strong on right to refuse treatment without making sure that she really understood what some of the consequences would be? Or are there dimensions of how the staff are going to feel and respond to her if she's eating a regular diet and they are terrified that she's going to aspirate? On the other hand, it's her decision. So part of the how do you figure out what to do is also the pieces that have to be put in place around the family member and the staff. But that does not mean that Mrs. Irons doesn't have the right to make those decisions. I think the course of ombudsman action is what we were talking about in one of the previous slides in terms of stopping and slowing the process down enough, the rush to decision, to hear what people's concerns are, to know really what Mrs. Irons wants, and then to try to get everyone talking about a range of options and approaches that could be taken, and helping Mrs. Irons have some choices to make about her food and options, and making sure that she kind of understands the risk-benefit of each of those, but then supporting her in her ability to exercise choice and decide on her own values, and supporting her decision-making. In terms of how would you know if you've done the right thing, I think that's going back to the Ombudsman Code of Ethics in that list of questions that I gave you a few to look at in terms of internal questions to consider regarding conflicting interest. You go back and say, okay, have I taken the right course of action here for an ombudsman? No matter what the staff say or the family says, have I acted in accordance with good ombudsman policy, procedures, rules, and have I done what I needed to be doing in the Code of Ethics? And that's why we had that little checklist of questions. I wanted to run through a few pertinent pieces, pertinent to this case, of the State Operations Manual and the CMS guidance. And truthfully, it's sort of contradictory in some places with regard to pureed diet. As you've all stated, the resident has the right to refuse treatment and also the right to participate in planning care and treatment or changes in care and treatment. So you really wonder if she knew that her doctor was even saying she had to have pureed diet, or maybe the doctor did at some point in time and now she's functioning better and is better able to really stop and think, wait a minute, what does this mean? And there's a good chance the doctor wrote the orders on the chart and she really didn't have participation in it at all. So the guidelines to surveyors, the interpretive guidelines say, if there appears to be a conflict between a resident's right and the resident's health or safety, surveyors are to determine if the facility attempted to accommodate both the exercise of the rights and the resident's health, including exploration of care alternatives through a thorough care planning process in which the resident may participate. So that's really saying if the doctor says there's pureed diet order and the resident says she doesn't want it and she's tired of eating that, what options were pursued? In looking at the comprehensive care planning, the guidance to surveyors, state operations manual, talks about the regulations and the right to refuse treatment don't necessarily create a right for a resident or their representative to demand that the facility use specific medical intervention. And it's talking about care and safety. That has come up a number of times when family members were demanding bed rails or certain other kinds of physical restraints or even a chemical restraint that really was against a good medical practice and standards of care as well as the rest of the regulations. But one of the probes was interdisciplinary expertise utilized, and did the dietitian, and this is a specific example there, dietitian and speech therapists need to be involved in this, and do they determine optimum textures and consistency that provide both a nutritionally adequate diet and effectively use the capacities of the resident. And it may be that Ms. Irons needs a different kind of assessment at this point in time in terms of her abilities. There's a symposium that CMS convened a few years ago on food and dining and how to uphold choice and good care practices. And they had some commissioned papers, and out of that came some information around, based on this federal requirement on nutrition and reduced therapeutic diet when there's a nutritional problem. It also talks about restricted diets, which include a softer pureed, and residents on a modified, as might be expected, residents on these diets sometimes prefer a regular diet, which might put them at risk for choking. And it goes on to talk about the intent of the requirement and that the resident's personal wishes are acknowledged. Goals and prognosis refer to the resident's personal and clinical outcomes influenced by the resident's preferences. And in addition to that, it talks about one of the flags for severity scope of immediate jeopardy is that significant unplanned weight loss due to dietary restrictions or downgraded diet textures provided by the facility against the resident's expressed preferences. So there again, there's a lot of regulations and guidance to surveyors that kind of support what Mrs. Irons is saying she wants. And there was an excellent example, personal example, given in the symposium paper from Bonnie Cantor about her mother's diet. And her mother at that point in time just didn't speak. She was in a nursing home. She was on a pureed diet, which obviously she didn't like. And one day, two nurse assistants were talking about going to Wendy's, and this woman who hadn't talked in forever said, "Can I go too?" And everything stopped. And they asked her, "Where do you want to go?" And she said, "Wendy's." And they said, "What do you want?" She said, "Chicken nuggets." And actually, they took her out of the nursing home to Wendy's. She had chicken nuggets. She ate them very slowly with assistance, and she didn't choke. So there are all kinds of surprises in life, and sometimes they're very good surprises. And it goes back to listening to residents. We had another case scenario that we don't have time to get to today, but hopefully you will take the handout and go through it and kind of ask the same questions. We also pulled together some information in the slides, and we'll make this PowerPoint available to you, Carla, about ways to look at this particular situation and begin to gather information. And then the touchstones, this one had to do with potential abuse and neglect. And just like the help button, they're touchstones for ombudsman action. And it goes back to the person-centered complaint processing. The goal is the resident satisfaction. Ombudsmen are not the official finders of fact to substantiate abuse. And ombudsmen are not mandatory reporters. Before I get to questions, I wanted to just touch on some resources, and then we can see if there are any questions or comments right before we wrap this up. There are numerous resources on the Ombudsman Center website relating to ethics. We have long papers, we have short papers, we have a technical assistance guide and a brief. And then these papers like Applying Ethical Principles to Individual Advocacy, that's a write-up of a presentation that Joan Gibson did. And it takes some case scenarios, but it also has some ticklers and some bullet points about, think about these things, these are your guiding principles. And there are a few other ones like this. This one on Applying Advocacy and Ethical Issues, Multidisciplinary Approach Guide for Ombudsman, took a multidisciplinary case and had different disciplines talk about how they would see it, what they bring to it, and it talked about the ombudsman's unique role in working that through on behalf of the resident. And it really was an interesting exercise, as well as underscored the need for ombudsmen to be totally focused on the resident and making sure you have the right people involved in the conversation, because many times they can enlarge the options. And then in terms of the role of the ombudsman with responding to allegations of abuse, there are many, many, many options for ombudsman activities and support for residents when there are allegations or in fact abuse, neglect, exploitation. But ombudsmen can do a lot of different things to support that resident before, well, during and afterwards, that nobody else can do. But they're very appropriate roles for ombudsmen, but are very different from the roles of law enforcement, the survey agency, and that of adult protective services. So this technical assistance brief provides a lot of guidance and examples around what ombudsmen can do, and that's also on the NORC site. Amity, let's open the lines and see if there are any comments or questions that you have that you'd like to ask in the remaining 2 or 3 minutes that we have together.
Thanks, Sarah. The lines are open.
It would be interesting with the grade line, it was the staff that requested it, or was it the position order, if the position order the staff recommended it?
Sarah, the comment made was it would be interesting to know who ordered the staff or the pureed diet, whether it was on the recommendation of the staff or it was based on purely on the recommendation of the doctor. Any other comments? What was that, Debbie? Okay, and the ombudsman who submitted the situation said she failed the swallow test, so that it was ordered by the doctor. Any other questions or comments? Sarah, go ahead.
I missed what you were saying about the ombudsman who had that situation or a similar one. What was the rest of that statement?
The parade diet was ordered by the doctor because the resident had failed the swallow test.
Oh, okay. So there are, yes, it's interesting to know that, because many times some orders get written, whether it's for pureed diet or some other reason, that the staff call and ask for the order to be written a certain way. But sometimes physicians have their go-to responses for certain things too. And there's been so much work out in the nutrition and dietary standards field with many, many, many kinds of innovative options that may be an acceptable compromise for Mrs. Irons. On the other hand, it may be that Mrs. Irons doesn't really care. It's more important for her to have food that she values and thinks tastes good and looks like real food than it is to live another week, a few weeks or months. And then it may be that certain foods are more prone to being aspirated than others, or there are certain techniques to use in providing assistance in eating that may minimize that possibility. So it's being thoughtful about what are the issues, what are the values, what are the real conflicts, and what does Mrs. Irons really want. It may be that she would accept a different kind of soft diet that's not pureed, or certain foods or ways of preparing them may be okay that wouldn't be quite as much of an issue for her. Or, it may be no, she wants what she wants, and no matter what, that's what she wants. Sometimes it may be helpful for her to have a conversation with family and try to and the resident and staff, and try to get it back focused on what are the real values here? What does everyone most want as the outcome? And then move back from that outward to how do you get there, or what are the closest ways we can come? And then pulling in a range of people with different kinds of professional expertise to begin to offer some other options that may work. Well, you can reach us through the website. You can call us. We appreciate the opportunity, and the hour has gone really quickly. But Carla, I'll send you the PowerPoint. And if there's anything else that we can do or that would be helpful on this topic, let us know. I appreciate your participation. I know it's a struggle when you're in a room with a number of people and there's one speakerphone, and it's pretty much a one-way conversation for a topic that's actually very complex. But I wish you all well and appreciate the advocacy that you do each and every day on behalf of residents.
All right. Thank you so much, Amity and Sarah, for presenting this. And you're absolutely right. It just, the issues back and forth with the microphone makes it challenging. But thank you so much. It was very informational and helpful.
Thank you for working with us.
All right. Bye-bye.
Bye. Bye.